A very good evening to all. And so that to be in time, I think we can start since it's already 4. So a warm welcome to everybody who is there present in the room for the very first midterm AIOS conference along with the opening Glaucoma session 1. I'm happy and I'm glad that I'm able to introduce all the eminent speakers who are going to present a vast variety of topics today and I am also honored to welcome all the eminent panel people, Chairperson Dr. Pandav sir, Co-Chairperson Dr. Arup sir, Convener Dr. Maitreyi ma'am, Co-Convener Dr. Chitra ma'am, and moderator myself, Dr. Shweta Tripathi, would be taking you along to the entire journey of a nice discussion amongst the different topics of glaucoma. So with this, we start the very first presentation for today, that's glaucoma. The silent thief of sight, we can prevent the vision loss by the early checkup. Dr. Sanjeev Kumar.
A very good afternoon to all of you. Glaucoma is the second most common cause of blindness worldwide. And in India, at least 12 million people are affected by, and nearly 1.2 million people are blind from the disease. So the burden is huge. IOP is important and modifiable risk factor in glaucoma, and tonometry is the procedure performed to determine the intraocular pressure. I will limit my talk mostly to the tonometry. So a brief idea about the history of tonometers. In 1826, it is the William Bowman who used to digital tonometry in routine clinical practice. And in 1863, Von Griffith designed the first tonometer. In 1885, it was the Makalakov who designed the Aplanson tonometer, and 1905, Seuss designed his indentation tonometer, and that has made tonometry a routine clinical practice. This is the Von Griffith tonometer, and mostly the tonometers are of two types, contact and non-contact tonometer. In contact tonometer, it is indentation in Seuss tonometer, and applanation with variable forces, Goldman applanation tonometer, Perkins, tonopena, and pneumotonometer. And with constant forces, Makalakov. And non-contact tonometer is Pulsar. In the picture, we can see that first one is indentation, Seuss is based on that, and the second picture is applanation tonometer. This is the most accurate method of IOP estimation manometry, but it is measured by inserting a cannula directly into the anterior chamber, which is connected with a manometer, but this is not practical clinically. This is a Seuss tonometry. We all know that it is based on the principle that if a fluid-filled sphere is indented by plunger, the plunger will sink in the globe till the pressure of the plunger is equal to the pressure inside the globe. Oh, this is all about principle. Advantage of this is cheap, easy to use, and does not require straight lamp. And its advantages are IOP is influenced by ocular rigidity. Low ocular rigidity in case of high myopia, myotics, masculitis, and thyroid ophthalmos, falsely low IOP, and high ocular rigidity like hyperopia, macrophthalmos, and vasoconstrictors, falsely high IOP. Now this is the important because mostly we all are doing it, and it is based on the Imbert-Fix law, which states that the pressure inside an ideal dry thin-walled sphere equals the force necessary to flatten the surface divided by the area of flattening. This is all about technique. Important point here is the angle between illumination and the microscope should be around 60 degrees. A pattern of two semicircles seen one above and one below the horizontal midline, and the dial on the tonometer is rotated to align the inner margins of the semicircles. That is important. And this is about the semicircles and bifurcation of the probe. This is important. Sometimes we see the thick Myers, and that will lead to overestimation of the IOP, and it is due to excessive staining with the fluorescent stain. And to correct this, the excessive fluorescent stain should be washed out. In case of thin Myers, it will lead to underestimation of the IOP, and it is due to measuring the IOP over a long time period. So to correct this, ask the patient to blink a few times. Sometimes there is too large a applanation surface. This is due to forward moving of the slit lamp, and to correct this, withdraw the slit lamp until the regular pulsating mire appears. Sometimes eccentric mires, so proper centration of the bioprism should be done. Unequal mires, it leads to overestimation of the IOP, and correction is by proper height adjustment of slit lamp. The sources are fossil low IOP in case of thin cornea, corneedema with the rule of stigmatism, prolonged contact and repeat tonometry, because there is softening of the eyeball. And falsely high in case of thick cornea, steep cornea against the rule of astigmatism. Sometimes we put too much pressure on the globe. That will lead to falsely high IOP. Sometimes excessive squeezing of the eyeball by the patient. It also leads to increase in the IOP and in case of thyroid myopathy, because there is restriction of the extraocular movements. This is about Perkins tonometer. It is based on the same principle as that of Goldman, and being portable, so useful in measuring IOP in infants, children, bedridden, and sterilized patients. Now coming to the tonopen, the probe tip contains transducer that measures the applied force. It is based on the both indentation and applanation principle, and being portable, so useful in children, irregular surface and edematous cornea, and through the amniotic membrane patch graft and even on the soft contact lensage. Eye care tonometer, it is an updated version of indentation tonometer, and a very light disposable sterile probe is propelled forward into the cornea, and the time taken for the probe to return to its resting position and the characteristic of the rebound motion are indicative of the IOP. The advantage are, results are comparable to the Goldman applanatometer and useful for screening purposes, and disadvantages are not useful in corneal scarring. Palpable tonometer, it is used in situations where other devices are not useful, like children, demented patients, and mentally challenged patients. Pressure on the eyelid produces retinal phosphins, and the force required to produce these retinal phosphins is proportional to the intraocular pressure. This is important. Dynamic contour tonometer, and this is the most accurate tonometer till date we have. And it is based on the principle that by surrounding and matching the contour of the sphere, the pressure on the outside equals the pressure on the inside. And it is IOP displayed on the LCD screen. The DCT indicates the magnitude of difference between the maximum and the minimum IOP of the ocular pulse amplitude. This is the graph of the ocular pulse amplitude, the difference between the maximum and the minimum IOP, as shown as the ocular pulse amplitude. DCT is superior in accuracy to Goldman applanation tonometer, and IOP is not affected by corneal thickness, and it is also not affected by corneal refractive surgery. Now coming to the NCT, it is based on the principle that a puff of room air creates a constant force that momentarily flattens the cornea. And the time from an internal reference point to the moment of flattening is measured by and converted to IOP. It is useful in screening programs, and disadvantages are air puff can be startling. Now coming to the ORA, this is also important. It is an adaptation of the non-contact tonometer. It directs air jet against the cornea and measures two IOP values, that is applanation pressure 1 and applanation 2, and two biomechanical values, that is corneal hysteresis and corneal resistance factor. And the difference between the first and second applanation pressure is called the corneal hysteresis. Corneal hysteresis is a measure of the viscous dampening and hence the biomechanical properties of the cornea. The average of the two IOP provides a Goldman correlated IOP measurement. While the IOP varies over 24-hour period, but the hysteresis seems to be stable. And corneal hysteresis measures IOP that is less affected by the laser refractive surgery. Condon et al. Found that low stress values are at greater risk of glaucoma progression. This is the difference between the applanation pressure 1 and applanation pressure 2 is called the corneal hysteresis. If we don't have any tonometer, nothing to worry about. We have digital tonometry. If it indents easily, low IOP, firm to touch normal, and stony hard in case of high IOP. These are the criteria of ideal tonometer. For screening COs, eye care and NCT is good. For gold standard is Goldman applanation tonometer. Most accurate till date is dynamic contour tonometer. Implantable tonometer, probably this is the future because we can record the IOP over 24-hour period. And ideal tonometer is yet to come. Thank you.
Thank you, Dr. Sanjeev Kumar. It was a wonderful presentation. And in the interest of time, we will take the questions in the last. Just one line. I would request Arup sir to share his experience regarding this early prevention of glaucoma by picking up the thief in time. So, I'll get the mic.
Yeah. So thank you, Shweta, for asking this question, raising this issue. It is actually not only the intraocular pressure that I go by. I mean, it is basically a host of factors that allows me to pick up a glaucoma patient at an early stage. Of course, whenever I have a glaucoma suspect, I'd rather go by what the intraocular, rather than what the intraocular pressure is like, by what the optic nerve looks like, and then whether that is parallel by digit, the field charting C30-2, and then I take the tonometer into account, and the central corneal thickness also forms an important part of the whole diagnostic decision.
Thank you, sir. Now may I invite my next speaker, Dr. Richa Gupta, to deliver her talk on gonioscopy, tips and tricks. And I know this is a field where the beginners, they are really worried about touching the gonioscope. So I'm sure that after this presentation, everybody would be able to take some tips and tricks shared by Dr. Richa.
Thank you, Dr. Shweta. So this is indeed a basic presentation on how to do gonioscopy. And so we'll be learning the technique and the general guidelines for using this tool. And this is basically to encourage the ophthalmologists and the postgraduates to practice routine gonioscopy. So this actually forms a part of complete ophthalmic examination, which as ophthalmologists, we should be able to perform in all our patients. So what's the principle? Why do we need this special tool? That's because the light which comes from the angle gets totally internally reflected, and the lenses change the interface from cornea air to lens air, and thus permits the view of the angle. So we have direct gonioscopy, where, for example, Copies and Swan-Jacobs lens, and we have indirect gonioscopy. So indirect also is of basically two types, the Goldman type and the Zeiss lenses. So the basic difference is a Goldman gonioscope needs a coupling solution because it has a large diameter, and a Zeiss lens does not need a coupling agent. It has a small diameter, and indentation can be done with the Zeiss lenses. So what are the indications? The Van Herrick's test, which shows a shallow angle, is one of the major indications for doing gonioscopy. But if negative, and we don't do a gonioscopy just by relying on the Van Herrick's, we may miss 2% of the occludable angles. So to differentiate between various glaucomas and to diagnose secondary glaucomas, to look for any secondary abnormality in the angle. Therapeutic use could be in trabeculoplasties and indentation gonioscopy to break an attack of angle closure, or to assess the treatment post-peripheral iridotomy and trabeculectomy. So first and foremost, we have to explain the procedure to the patient, apply topical anesthetic agent, apply the coupling fluid if needed, and the patient is asked to look up. Next, the lower edge of the gonioscope is placed at the lower lid and tipped onto the cornea very smoothly. And with the lens on the eye, the patient is asked to look straight, and this you'll be able to do if you look at the other eye. So having decided to learn gonioscopy, what's the best method? So at Shankar Nethralaya, we were told that you should be doing at least 500 normal gonioscopes to actually come to a diagnosis in an abnormal patient. So unless we know what is normal, how can we detect the abnormal? So let's come to the normal angle structures. So first and foremost, the anteriormost comes the Schwalbe's line, which is nothing but the termination of the Descemet's membrane. So it may be seen as a sharp line projecting into the AC. This is how it looks, the yellow arrow. Next comes the trabecular meshwork, which has two parts, the anterior, non-functional and non-pigmented, and the posterior, pigmented part. And Schlemm's canal lies deep to it. So this is where the red arrow shows that. And next comes the scleral spur, which is the most anterior projection of the sclera. And it's the site of attachment of longitudinal muscle seen as a dense white band, which is the blue arrow. And next is the ciliary body, which is nothing but a dull brown slate gray band. And there is an angled recess posterior to it, which is nothing but the dipping of the iris as it gets inserted into the ciliary body, the blue arrow. So once we are doing it, we should have two questions in our mind and we should be able to answer both of them while doing the gonioscopy. Number one is the angle occludable? And second, is there abnormality in the angle? So to answer the first question, we have to look at the posterior pigmented trabeculum. If it's not visible for more than 180 degrees, then the angle is closed. But a very important catch in this is it should be an in situ view of the angle. That is, it should be without indentation. That's one of the most important points in this. Okay, so how do we do it? The room lights are dimmed, illumination and height is decreased so that the light does not impinge on the pupil and does not cause constriction, and then the angle is observed. So this is the Schaeffer's angle grading. So coming to any abnormality in the angle, for this, we need to constrict the pupil so that we'll have a look at the angle. So we increase the slit lamp illumination, so the pupil constricts and then we have an open view of the angle. So while using Goldman lens, we will not be able to indent, as I told you earlier. So we manipulate the angle. We ask the patient to look in the direction of the mirror, which we want to look at. So this is how an indentation works. Once you press at the center of the cornea, it opens up the angle, and then that is how we look at the angle, any abnormality in the angle. So this is how the angle looks. The left side is before indentation, not able to see any angle structures. Once you indent, the angle structures are visible. So let's look at few of the examples. Here are two similar looking angles, right? The top one and the lower one. What's the difference between the two? So one, I'll tell you, is abnormal. One is a normal angle. So these are the two structures which may be visible. One is an iris process, which is a normal structure. So few important pointers are, it extends only up to the scleral spur and follows the concavity of the iris. Pars is broad and it goes beyond the scleral spur. And that is an abnormal structure which is present. So the top one is pars and the lower one is an iris process because they are fibrillary and it's stopping short of the scleral spur. So if you see something like this, very florid neovascularization of the iris, I think the time is up. I'll just conclude. And
one more minute. One more minute is
right.
there with you.
So there are new vessels in the angle. That's called NVA. So, and if you see something like this, and a grossly pigmented angle, the diagnosis of pseudoexfoliation is made. Something like this, both the angles are post-trauma. So the top one is angle recession, and the lower one, we have already seen a case in the last session. It's a case of CD cleft. So there is foreign body and melanoma of the iris, which is visible. A case of Sturge-Weber. So you see the vessels, episcleral tortuous vessels, and in the inferior angle, you have the blood in the Schlemm's canal. So this is a case of Booth-Thal-Moss with rudimentary angle. So congenital glaucoma. And this is a very interesting group of photographs. So the top one is a narrow angle, right? And once we indent the next one, we see that the angle is opening up on indentation. After PI, you see there is a significant deepening of the angle. So that is the normal, how the sequelae of PI is seen. So the recording has to be done. 4 basic things are done. You have to look at the most posterior structure and mention that. Shape of contour of the peripheral iris is noted, the degree of pigmentation and any abnormal structure that is seen. This is the Becker's goniogram. Traditionally, this is how the angles were noted, and these are the suggested readings. Thank you so much.
Thank you, Dr. Richa. So we move forward to the next talk, which is going to be presented by one of the most experienced people in the field of glaucoma, Dr. Manoj Mathur sir. And he's going to talk about structural and functional correlation in diagnosis of glaucoma. That's really something, if you get the hold of it, no cases are going to be missed by you. Dr. Manoj sir.
Yeah, thank you, Dr. Shweta. Thanks, Arup. Thanks, the other panel members. So, as Arup said, it is just not the intraocular pressure that should lead us to the diagnosis of glaucoma. The most important thing that is required for diagnosis of glaucoma is the structural and functional correlation. And how do you establish that? In this basic clinical talk, let us see how to evaluate basically the disc, corroborate the OCT, functionally correlate with the Humphrey, and then structural and functional correlation forms the cornerstone for the diagnosis of glaucoma. So these are the 7 parameters that should stare at you the moment you look at the optic disc. What are these? Number 1 is the optic disc size. Make a forced decision as to what is the size of optic disc that you are looking at. On the left, you see a small optic disc compared to the size of a Welch-Allyn spotlight. And on the right, you see a large disc. Why the size of the disc is large, we come to know. The next is the common thing that we all know, the optic disc cup, the cup disc ratio, and the vertical cup disc ratio is more important, and the cup disc asymmetry between the two eyes needs to be looked at. When we see 3 normal discs in one picture, small disc, medium disc, and large disc. The lesson that we learn from here is that CDR varies with the disc, with the size of the disc. That is why you must make a forced decision as to what is the size of the disc you are looking at. And cup disc ratio on its own is not significant. What it means is a large cup can be normal for a large disc and a small cup can be abnormal for a small disc. So what stands out is that importance varies with the disc size and it is a surrogate for the neuroretinal rim. What you must look out in the case of glaucoma is the health of the neuroretinal rim, which needs to be pink, or whether there is a pallor or if there is a focal or local notch. And one more important thing you should look out for is the so-called isn't rule, that the inferior neuroretinal rim should be thicker than superior, should be thicker than the nasal, and the last is the temporal. The vascular changes, we all know the nasal shift of the vessel, bearing of the vessels, and the bioneting of the vessels, and the optic disc hemorrhages. Optic disc hemorrhage won't look at you. You have to rule out an optic disc hemorrhage whenever you are evaluating the disc. And the nerve fiber layer defect, it touches the optic disc and fans out into the periphery, better noted with a red-free light. The peripapillary atrophy arising de novo can be pathognomonic of glaucoma and not a pre-existing one, and the chorioretinal degeneration can suppress the sensitivity overall in the Humphrey visual fields. So after seeing this, how do we corroborate with an OCT here or RTView printout? It is the combination of the RNFL thickness and the optic nerve head shape that increases the diagnostic power. The ganglion cell complex is also an important, significant factor in the RTView machine. This is the normal printout. You must corroborate the patient details, the test net graph, and the summary table. And then comes the functional correlation after establishing and corroborating the structural defect. This should match out with the functional changes in the visual field, the 8 important segments of the visual field that you must know. And when you, in one slide, try to discuss the visual field, on the left you see there is dense suppression in the total deviation plot. When the diffuse suppression is cut off from the total deviation, what stands out as the normal points in the pattern deviation can be a pure case of cataract. What you see in total deviation significantly being persistent in pattern deviation can be frank glaucoma. Total deviation is fully suppressed. Focal defect spanning out in the pattern deviation can be a cataract and glaucoma. This is how basically, because of the paucity of time, in one sentence I'm interpreting the visual fields. And now the structural and functional correlation. Basically, I told you the size of the optic disc. Here you see a large disc with a large cup. 3 decades back would have been a glaucoma case, no longer anymore, because the health of the neuroretinal rim is not good and the visual field is normal. Here if you see, there is an inferior temporal notch manifesting as a focal defect in the superior nasal step. Here if you see, there is a dense excavation in pallor of the superior optic nerve, optic rim, which manifests as an inferior arcuate defect. In this case, if you have to differentiate between the color cupping and the contour cupping. If you see carefully the dipping of the vessels, there is a wide near total contour cup manifesting as a dense defect in the visual field. These cases should be repeated with a 10-2 printout to have a proper follow-up prognostic value for the visual field. And invariably, whenever you detect a temporal pallor of the optic disc, don't be surprised if you get a hemianopic or rentanopic defects. This is the other eye. So in the case of bilateral pallor, always subject these patients to a Humphrey visual field to rule out any neurological deficits. Here if you see, there is an inferior temporal excavation. If you see carefully, there is a retinal nerve fiber layer defect which is spanning out into the periphery. Corroborate with the OCT, there is inferior temporal thinning, significant ganglion cell loss, correlating exactly as a focal defect in the superior nasal step. This is the structural and functional correlation that you need to establish for the diagnosis of glaucoma. Here if you see there is a inferior excavation of the neuroretinal rim and a possible small superior temporal thinning as corroborated in the OCT, manifesting as a then superior arcuate defect with encroachment into the macula, and then the focal defect in the inferior nasal step corroborating with the superior temporal segment in the OCT. This is how you have to correlate structural and functionally to establish the diagnosis of glaucoma. Hemorrhage, as I told you, never looks at you. Rule out a hemorrhage. Here you see a hemorrhage in the superior temporal segment. Initially, the normal OCT, normal visual field. 3 months down the line, if you see the visual field on the right side, there is a slight one spot defect in the inferior nasal step. This is how you have to follow up the patient and try to manage a case of glaucoma. Last but not the least, this last case I would like to show. Like this is my learning defect, the learning curve in the interpretation of the OCT. When I had the machine, just because there was a difference of 19 and 14 between the two eyes, I just subjected this patient to visual field and then the OCT. I detected in the right eye superior temporal and inferior temporal the thinning. Then I went back, had a relook at the right eye, then I started seeing some sort of a RNFL fiber layer defect there. Then I learned about the GCC complex in the RTView printout. After 4 months, called the patient back, the superior temporal and the inferior temporal segment is no longer there. Go back and review. In the month of April, there was a STIT segment thinning. In the month of November, it is no longer there. What is the reason? If you see the centering of the test done, in April, the test done was decentered, a more peripheral point was tested, and that was the reason for the superior temporal, inferior temporal defect. Whereas in November, 6 months down the line, when we repeated the test, the concentration was perfect, and there was no nerve fiber layer defect detected there. So, according to the OCT, the imaging technologies do not confirm the diagnosis by themselves. Imaging technologies at best only complement the clinical judgment of the glaucomatologist. Structural and functional correlation by stereo photographs and visual fields is a vital tool. A good collaboration with the relevant imaging technology does act as a bonus. Thank you very much for your patient hearing.
Thank you, sir, for beautifully figuring out the importance of correlating both the structure and function when it comes to glaucoma diagnosis. Now may I invite our young, dynamic innovator, Dr. Prasanna Venkatesh, who is going to deliver his talk on rethinking 10-2 visual fields in early diagnosis of glaucoma. Till then, I can request Dr. Maitri, ma'am, to share her tips and tricks about gonioscopy. Since I can see a lot of young ophthalmologists sitting in this room, ma'am, anything would you like to just share with them as just one liner for gonioscopy?
Practice, practice, and practice.
I think that's the sutra. That's the sutra for gonioscopy and glaucoma
Hello.
practice.
Take a 4 mirror. I feel like getting a 4 mirror. Though it is very depressing in the initial period, but if you start doing it with a patience, just keep doing it. When I was a student and Dr. Vijaya madam asked me to buy one 4 mirror gonioscope, that was an Indian version with a handle that Apasami people used to make. It was very cheap also. So I started doing it and I used to get lot of things other than the angle. So, and all these patients in the Shankarnetala OPD is a very busy OPD. To get time also to do the gonioscopy is really difficult. And the morning when I used to come and start the patient without dilatation, I started doing it. That time also I was not getting any structure. I told you I was not getting anything other than the angle. But have patience. One day we'll get it. And once you start getting it, you will get it. So try it on high myop patients. Keep doing it, and that is the only, I think, the basics of gonioscopy.
Thank you, ma'am. And Dr. Prasanna, are you ready with it? Yeah, so go ahead.
Thank you for this opportunity. So my topic will be on rethinking 10-2 visual fields for early glaucomatous diagnosis. So traditionally we were taught that visual field declines in the periphery in glaucoma, and only when there is a tubular vision, then 10-2 was actually ordered to monitor progression. That was an old school of thought where damage near fixation can happen only in the later stages, which is actually wrong. Let's see why. Take for example this patient, a clinically diagnosed glaucoma suspect. An early visual field defect may actually be missed on 24-2, whereas the same defect can be exaggerated or easily picked up on a 10-2 as seen on the right hand side. So in 30-2 and 24-2, what happens is in 30-2 there are 76 points and 24-2 there are 54 points. But the real thing is only 12 points are checked in the 30-2 or 24-2. If we count in the central 10 degrees of the 30-2 or 24-2, only 12 points are checked, whereas on the right hand side, you can see that in the 10-2 field, 68 points are actually being checked. So that really makes a lot of difference. As you can see on the right hand side, red arrow showing the 68 points being checked. Again, coming back to the same case, so early visual field defect may be missed on 24-2, same picked up in 10-2, and as Manoj sir was rightly pointing out, always correlate the 24-2 with the RNFL thickness, structure function correlation. Similarly, when you see the 10-2, make sure you go back to the ganglion cell inner plexiform layer and correlate the 10-2 with the ganglion cell inner plexiform layer. Again, in this patient, what we easily would have missed in an RNFL and 24-2, we are picking up it in a 10-2 on a ganglion cell inner plexiform layer. That's what structure function correlation really plays a lot of role in that. So ganglion cell layer damage can happen in the earlier stages as well, and it can be sometimes the only manifestation of early glaucoma. Drans was the first to point out this because 30% of the retinal ganglion cells and 50 to 60% of the primary visual cortex is actually supplying more information in the macular region. And it's anatomically proved, and there are many papers which are coming out with this publication by Curcio et al. And Curcio and Allen, which started in 1990. The real problem is when we see a patient like this, where 24-2 is perfectly normal and we see the RNFL, we are thinking it's okay, it looks to be normal, but when we do a 10-2 and there is something that is picked up, that's when the reality changes, where we can early diagnose that patient and start therapy. So again, the main thing is there are 3 permutations and combinations that we will experience in our practice. One is the red block, which is very, very important, where 24-2 is normal, and when we do a 10-2, we may be picking up the damage. And the other 2 are more or less not very significant, where there is abnormality in 24-2. We'll end up getting an abnormality in 10-2 as well. Or the traditional type C is where the tubular vision happens, right? Because the periphery gets lost and then the tubular vision happens and then the 10-2 gets involved. That's the traditional school of thought. That is the inferior figure or the C figure. So the percentage is 6% of the eyes without 24-2 field loss exhibits 10-2. That's what literature has said. And it's really astonishing to see that among ocular hypertensives, 35% of them revealed only 10-2 damage where 24-2 was normal. Suspected glaucomas revealed 39% revealed only 10-2 damage, whereas 24-2 was normal. Early glaucomatous field, 61% had only 10-2 defects and no 24-2 defects. It's very, very significant because the whole classification, the whole severity of glaucoma can actually change because the central vision is actually getting damaged, and this can change the whole way glaucoma is being approached. So again, it's very important, the definition, the severity, the functional implication, everything changes. And how do we go about it? Alternate between 24-2 and 10-2, because in reality it's very impossible to order both in a single visit. Maybe we can alternate in once every visit, 6-monthly visit, once they can do a 24-2, once they can do a 10-2. Another important point is this is an animation created by me, where there is a single black point in your 24-2. If you see a single black point in your 24-2, now this is an indicator that you can go forward and do a 10-2 because only 12 points are checked in the 10 degree. Now, when we check 68 points, we get more information out of that. So how to go about? Another thing is, if there is an inferior temporal slit defect in your fundus, if you are seeing, again the study done by Zhang et al. Says do 10-2 for these patients. There is more prone for functional damage in this kind of patients. Again, clinicians should consider performing 10-2 even in established glaucoma because the diagnosis can change, the severity can change, the misclassification will not happen, and 10-2 is very important to set an important baseline Just like 24-2 and a fundus photo and OCT, it is very, very important. So this is the thing that I talked is my publication that is coming in the February 2023 issue in the Indian Journal of Ophthalmology. How 10-2 really incepted, this is a proofread file. I'm just sharing you priorly. What do we know from existing literature? And we have also talked upon a potential blind spot in Anderson's criteria, because Anderson's criteria doesn't really give us the 10-2 into the gameplay. So thank you once again for this opportunity. Last to summarize, correlate structure and function, as Mathur sir was pointing out, that's what is very important. Thank you.
Thank you, Prasanna.
Yes, ma'am. We'll always repeat it, ma'am. Yeah, one single visual field, yeah, we'll always repeat, ma'am.
As the next speaker gets ready, just one question for Venkatesh is,
Yes,
I think the baseline 10-2 is gaining in currency.
Yes, sir.
In fact, Journal of Glaucoma, the January 2023 issue, also said that baseline C 10-2 testing definitely, in many cases, I forget the numbers, it predicts the occurrence of abnormalities in C24-2. So I'm not really sure at this point, because the tradition has been to do C24-2 as baseline, whether, as you said, C10-2 alternative with C24-2.
Yes, sir. Maybe it's a bit of both is where
But
we'll be going.
I think it's a new concept that is gaining in currency, and I
Yes,
think
sir.
time will tell us what should be that.
Yes, sir. With time we'll know. Yes, sir. Current,
Basically, initially when we are taught, that time
Next
it was,
speaker on the screen,
it was said that the,
Just
yeah.
one second, I just call the second.
Sure,
speaker.
sure.
Is Dr. Sunil Kumar around? Yes, sir. So please be ready with your PPT, sir.
So basically, when we were a student, that time it was taught that the glaucoma affects from periphery to the center. But the recent theory is that the glaucoma can be multicentric in origin. So in the periphery also there could be some defect which can be picked up with the 24-2, and the central also, if it is a multicentric origin, then the center also there will be something different particular source. So you should get both the things done, especially the initial period.
So that is the bottom line, as the panelist comes with a consensus that 24-2 altered with 10-2. Am I right, sir, for the early glaucoma? So that's the take for this session, this particular talk. And now I introduce Dr. Sunil Kumar and welcome him and request him to start his presentation on etiopathogenesis of neovascular glaucoma, one of the most intractable glaucoma to be treated with. Sir.
Thank you, Sweta ma'am. Neovascular glaucoma, you well know, everybody. This is a very rare conditions. The prevalence is very low, around 0.1 to 5% around the world studies. But it is a very dreadful condition which leads to blindness, and we have, if we diagnose earlier and prevent the conditions due to neovascular glaucoma is occurring, so we can treat early and we can save the eye. So basically, retinal hypoxia causes the neovascular glaucoma by hypoxia-induced factor, pro-angiogenic growth factors, and ultimately the neovascularization in the rim, and then angle, and then grow into the trabecular meshwork, and blocks the trabecular meshwork and cause the neovascular glaucoma. So the most common conditions of the retinal anoxia are the proliferative diabetic retinopathy, central retinal venous occlusion, ocular ischemic syndrome, and intraocular tumor and trauma. This all leads to the angiogenic activity in the eye. Other uncommon conditions are also which causes the retinal hypoxia, which I am not going to the details of that. What I want to concentrate on how this ocular angiogenesis occurs due to retinal anoxia. Actually, there are two types of the factors act on the endothelium of the vessels. One is pro-angiogenic endothelial growth factors, and other is anti-proliferative factor. Actually, body maintains a balance between these two. When pro-angiogenic growth factors overrides others, the endothelial proliferation is initiated. Retinal anoxia stimulate molecular switches present in the body that regulates the homeostasis of oxygen in the tissue. These molecular switches has been named as hypoxia-inducible factors, which is the master regulator of homeostasis of oxygen in the body tissues. This HIF is a transcriptional protein that acts on such genes just like VEGF and INOS inducible nitric oxide synthetase, which can combat oxygen crisis in trauma, stress, or supply block due to any cause. Due to this action of the HIF, there is an upregulation of the pro-angiogenic growth factors like synthesis of growth factors, secretions of growth factors, inflammatory mediators like cytokinin. These are the different growth factors, vasculars, VEGF, basic fibroblast growth factors, tumor necrosis factor, insulin growth factors, platelet derivative growth factor, angiopoietin 1 and 2, and TIE2. The retinal anoxia or ischemia or hypoxia happens due to any cause which results activation of the hypoxia-induced factor, inducible factor, which results tissue microenvironment tries to adapt with the hypoxic conditions. That results stimulation the process of improving circulation and increase oxygen supply by increasing circulation or decreasing oxygen demand on the temporary basis or for long term as per the requirement. The pro-angiogenic growth factors alter tissue microenvironment according to the hypoxic situation, reprogramming the metabolic pathway, increasing vascular permeability, maintaining homeostasis of the oxygen concentration in the tissue. Sometimes, as the requirement, there is a short type adaptation. This is microenvironment of the tissue is altered according to the hypoxic condition by increasing the oxygen supply. How? This is upregulation of the receptors and secretions of the enzyme like inducible nitric oxide synthesis. That results the increased production of the nitric acid oxide. That relaxes the vascular smooth muscle wall and oxygen supply is increased. The another short-term adaptation method is that the decreasing oxygen demand, mitochondrial respiration is reduced, cell production is decreased by upregulation of the cyclin-dependent kinase inhibitors, glucose uptake is increased, glycolytic enzymes are more utilized, and we are decreasing that decreases the oxygen demand. Now, long-term adaptation is if there is required long-term adaptation is regulated. It is also by the HIF. All this expression of the pro-angiogenic growth factors, genes, VEGF, others, activation of the pro-coagulating factors, activation of the inflammatory mediators like cytokinin, which is a potent angiogenesis stimulators, angiogenesis is stimulated. So this is a chart of both short-term and long-term initiations. The regulator of the pro-angiogenic growth factor is HIF, the master regulator, depends upon the amount of the hypoxia and the duration of the hypoxia. The migration of the cell, HIF stimulate pro-angiogenic growth factors. This VEGF increases vascular permeability with the help of the nitric oxide, extravasations of plasma protein and fibrinogen. Fibrinogen is converted to fibrin and provides a provisional extracellular matrix. HIF stimulate pro-angiogenic growth factor. Sorry, this repeated. And this is the chart which is giving the migration, proliferation, survivor permeability of these vascular and epithelium growth factors. So there is a tip cell which is a specialized endothelial cell which migrate to ECM, stimulates endothelium cell for proliferation, endothelium cell move to the ECM due to degraded basement membrane, detached smooth muscle cells and loose paradise, ECM matrix, that is repeated now. Yes, there is vascular bleeding. Migrated proliferated endothelial cells organizes or differentiate into highly proliferative stalk cells. These stalk cells further differentiate in lumen of the vascular bud and sometimes sprouting from the vascular bud. This vascular bud advances under regulation of the pro-angiogenic growth factors and new capillary vessel forms without few parasites. And thank you.
Thank you, sir, for such a detailed presentation of the etiologenesis of NVG. So only if you know the stage at which your stage is there of NVG presenting, you can plan your treatment accordingly. So now, again, I invite my next speaker, Dr. Anil Kumar Singh. Is he around? Dr. Anil Kumar Singh. So that leaves us with the conclusion of the session, with the discussion, having time for discussion. So my question with Dr. Prasanna would be just one question, that Dr. Prasanna, how frequent do you recommend, because after this session, there should be some bottom liners which should be conveyed to the audience, that how frequently do you recommend this 10-2 for your early glaucoma cases, altering with the 24-2?
Ma'am, initially I was doing one visual fields a year. Now at least I am trying to do one visual field of 24-2 and one 10-2 once every 12 months or once every 18 months, depending on that particular patient, ma'am. Fundus photo and OCT also once every year, but since visual fields, I'm ordering 2 visual fields once every 12 months or once every 12 to 18 months is what I am actually doing.
So that means first you order for a 24-2.
24-2 is
and
what
then
I do.
after 1 year down the line, you order for 10-2.
10-2. Yes, ma'am. Sometimes, yes, sir. Mostly, some of the patients we do both the fields also, depending on the time of some people. If they want to really go off early, or if they are not able to perform the visual fields very quickly, depending on the patient's expectation is what I really see, sir. Because time consuming is one thing. If they are very capable enough to perform the visual field, then we are doing both the visual fields also at a single visit.
And
I would advise if a patient, there is a glaucoma suspect and
Okay,
you do the fields, and you wouldn't want to, there could be a learning curve issue or all. Of course, if the fields is normal, then you are reassured, then you know you might call him after a year. But if there is some suspicion, then the field should be done. It need not be every 3 months if it's something so basic, so unsure. But you should not keep it for a year and 18 months. You should have
yes,
done
ma'am.
it in 6 months interval at least.
Ma'am, those 3 criteria which I was saying, ma'am, in 24-2, if I see a single spot in the central 10 degree, then at that day itself we do the 10 degree fields also. Yeah, the take home point is if there is a defect, even a single black spot in the 24-2 field in the central 10 degrees, that's it, that day itself we'll do it. But for generalization, I don't feel that's possible.
Basically, if you have a very strong suspicion that you are going to get some abnormality in the visual field, if you have that kind of suspicion, so it depends, you should customize actually. So if you have a very strong suspicion that you will be getting some defect in the visual field, which you are not able to pick up in 24-2, you are jolly well welcome with the 10-2 and follow them up with both the fields.
Yes, ma'am. Sometimes for moderate and severe glaucoma patients, maybe I'll do it 6 monthly or yearly, but as ma'am was also rightly...
No, I think moderate glaucomas, even early glaucoma, I think once in 6 months you should do it. And advanced glaucomas, I think even once in 4 months you should do it. Because you can change your medications and all, because just one odd recording of IOP is not going to tell you how the IOP is going to fluctuate during the day.
Yes, sir.
What I feel is like if you suspect like on structural correlation, like when you are assessing your optic disc, if you have a slightest suspicion of a possible nerve fiber layer defect and still the visual field is normal, such cases should be immediately subjected to 10-2.
And sir, what is the take of the panel on the difference between, because young people are there, so how do they differentiate between the points of 24-2C and 10-2? Because that is having an edge of 24, there is a difference between 24-2 and 24-2C, which the new Zeiss machine is coming up with. So I would like to just...
Yeah, that is a hybrid of 10-2 and 24-2. That is probably like once that machine is available everywhere, that will be the gold standard for a start of visual fields. Then based on the interpretation, we can further subject that patient to 10-2 if required.
Yes. So that's...
24-2C is available in the Indian market now, basic machines. We are talking about not 24-2C, we are talking about 24-2 versus 10-2 in glaucoma suspects. So patients where we already have established glaucoma and being followed up, that is okay to do, because 10-2 still may predict 24-2 patients are going to progress much more rapidly. You do 10-2, that means you step up your therapy or you take up the patient for surgery. So that's a different scenario. We're talking about a scenario where you have a glaucoma suspect and just a suspicion, 24-2 traditionally we do that is normal. Then 10-2, then subsequent follow-up will be 10-2. I think every 6 months is something which I would prefer to do rather than waiting for a year. Of course, all this will require a lot of counseling, and patient should really understand your intentions. And
Because sometimes it tends to cut on the fundus photo and OCT, sir. I don't want the patient to think over-investigation
No,
is also.
I used to also think when I earlier days that repeating frequent fields, the patients are not going to be happy. I now believe that fields is the way I am going to go to manage my patients. And all my patients understand, and all of them get the fields as and when we tell them. And I also don't deal with the very, very rich patients. Glaucoma patients, surprisingly, are patients who are somehow just able to manage it. So I think you should ask for more frequent fields, not 1 year and 18 months and all that.
And coming to the 24-2C versus 24-2 and 10-2. So I had that opportunity to ask Dr. G.R. Reddy. So he told me in details that if you really want to pick up the early stages, 24-2 plus 10-2 is far ahead of 24-2C. So even in 24-2C, you will not be able to pick up the defects which you can in 10-2 because number of points tested in 10-2 is more than 24-2C.
Right. So the house goes with the consensus of that in early glaucoma, maybe you can do it annually or 10 months. In moderate glaucoma, you can go for 6 months, that repetition of fields. But in severe glaucomas, definitely 3 to 4 months. And in the meanwhile, if you see any kind of progression, please do assess your fields at a much frequent interval before labeling your patient that the patient has progressed. So you can just repeat it after a period of 1 month or 2 months. And then you label keeping other things in mind about progressions. That's entirely different topic about discussion. And just thank you, Dr. Prasanna, for clearing that. Yes, sir.
In fact, you have one point. Like, in fact, she referred to Dr. G.R. Reddy, like he's presenting a new he's projecting a new classification for glaucoma based on visual fields. Glaucoma beginning in the central field, glaucoma beginning in the peripheral field. So that should take us more forward as to where to suspect glaucoma. It is not uncommon that glaucoma begins in the central field.
Yes. Always be sure, sir. And sir, Manoj sir, since you very beautifully described about the correlation of the structure and function, I would like to request you to share with the audience that, tell them that not all the greens are normal and not all the reds are abnormal. Because that's a common thinking
Yes.
amongst the younger people, that red matlab to glaucoma hai hi hai. So please, just
So,
2 liners on that.
yeah, like that is the basic requirement of OCT when you are doing. Like red disease, there's a concept of red disease and a green disease. What it means is like, especially in cases of, as I showed you that case at the end, like proper centration of the image has to be there. The signal strength of the machine has to be good. Then there is a chance that in hypermetropes, where the size of the disc is apparently small, the area tested is more peripheral. In such a situation, like there can be a concept of the disc, the OCT coming normal, whereas in high myopes, the calculation circle is very close to the disc, and there probably like you may end up with a disease on OCT. So structural and functional correlation is absolutely vital. Whatever defect, and glaucoma basically you have to look out for focal glaucomatous defect and not the diffuse defects. Like if there is a notch or a excavation of the neuroretinal rim, whether the Ising rule is being obeyed or not, whether it is a straightforward disc or a tilted disc. Again, tilted disc, the Ising rule is not applicable. So you have to establish a structural defect, and that defect should correlate functionally on the visual field. And that defect can correlate on OCT as a corroboration. That should be the cornerstone for the diagnosis of glaucoma.
Thank you,
So as regards the talk on gonioscopy, is Richa there? Okay, so anyway, Prasanna is here. So when I do a gonio photograph, I usually don't use the 4 mirror or 6 mirror. I don't get good quality pictures. I use the Magnaview gonio lens, which requires a lubricating or a viscous agent, and that gives me a much better picture. What do you do for the gonio photographs? I use a Magnaview gonio lens, which covers a big chunk of the angle, and it gives me wonderful
Yes.
pictures.
Sir, I am using Goldman 2 mirror lens with the Visco, and with that I am using the Amazon 700 rupee adapter which I learned from John sir. He taught me the technique. It's very novel as well as very cost effective. When we are taking the photograph, that time alone we have of course a good smartphone. We take that elephant boat is the name of that adapter, elephant boat adapter, which is 700 rupees in Amazon. We make sure one phone is always connected with that so that we don't always need to take the phone out, and also the database of that phone is 64 GB so that we don't need to really change the phones in between. So when we have a good case, Goldman 2 mirror is what I am using, sir. High magnification, take the phone along with the elephant boat adapter, connect it and take the photograph. Or rather than a photograph, sir, what I am doing is I take a video, and then after I take a video, I go into the software and then pause the frame which is very crisp. There I'll take a screenshot so that for publications and other things.
I think that's a better way of doing
Because
it.
sometimes in the patient, when we take a photo, we may not get the exact same thing. It gets slightly distorted.
So,
Another question which I want to ask the expert is, when would you decide to do a YAG PI if all else is normal, it is just appositional aneuplosia?
ma'am, you take the family history in mind, you take the need of dilatation, because if he's a diabetic or something like that, or if your patient is not willing to come for a regular gonioscopies, because sometimes definitely the PACS cases, they do need regular follow-ups. You have to counsel your patient on the very first sight. If they're not willing to come, then probably you can take the consult and go ahead.
If they have some amount of cataract also,
Yes.
would you, in those kind of cases, would you like to do a YAG PI?
PACS you are talking about?
Yes, yes. And cataract is also there. So the cataract is going to be progressing. And there is PACS.
No, I mean, in that case, of course, you convince the patient for cataract surgery. If the patient has a visually significant cataract, I mean, that is EACPA the question doesn't arise. But what I would like to give a take-home message is please do not take EACPA very lightly, because I have had a patient referred to me. Ultimately, we had to go for anterior chamber lavage. EACPA was done, there was hyphema, and intraocular pressure went up. Patient had a trabeculectomy, the original place. We had to do a lavage, all that, and the patient went for litigation. So I think it is something which is easy to do, but it can have sequelae. So that consent has to be taken and proper information to be given to the patient as to what things could go wrong.
Thank you very much. With that, we come to the end of the session, and we are very much in time. Thank you to the IT team. And with that, we invite the speakers and the panelists for the next session we are having here in the hall. And it's pertaining to glaucoma itself. So those who are interested can be seated back on the seats till we start the next session.